Hey everybody, welcome to the Health Babes podcast. I'm your host, Dr. Becky Campbell with Dr. Crystal Hohn. And today we had Dr. Rob Woodfield on. He's a board certified plastic surgeon and he specializes in breast implant removal surgery and advanced cosmetic procedures such as his no-cut facelift. So this was a great episode. We got all into breast implant illness, what you can do about it. He has a very specific approach to this, and it really falls in line with what we do with our patients as well. So he's amazing. I cannot wait for you to listen to this. And then he gets into some other procedures that, no cut facelift, some other skin tightening procedures. So we hope you love the show. Hey, everybody, let's welcome Dr. Rob to the show. We are so excited to have him. We have so many questions. We've asked on Instagram for questions, and we got an overwhelming amount because everybody wants to know about these topics.
All right.
So we're so excited to have you.
Thanks for having me.
All right, let's get into breast implant illness. This is something that has come up, what do you think, over the last 10 years, maybe 5-10 years more? And a lot of people have, when do you think the biggest boom for breast implants was? Putting them in the 80s, 90s?
Certainly in the 70s and 80s, it was prominent. And then in the 90s, there was a moratorium. And sometimes there's a little bit of uptick in things when you can't have them.
Yeah.
And then, it steadily, in plastic surgery, it's almost two time points. There's the younger folks who just, for whatever reason, didn't necessarily develop or have, concerns about the image. And that will give you a peak of interest in the younger group. And then there's typically a group after having children, and there's involution of the breast tissue and some stretching due to breastfeeding or weight loss, weight gain, whatever. So that'll be your second, peak. And that group is more of my avatar because I can do that with their own fat versus an implant.
Yeah. Okay. And I definitely want to get into that because I have a lot of questions about that.
Sure.
So, and I wish I would have known about that when I got my implants put in when I think I was 19. I grew up in South Florida. So that's everyone has them here.
I'm from Las Vegas.
Okay. So very similar. So let's talk about, anyway, people were starting to not feel well and starting to relate them to their implants. So let's just kind of do a quick, what is breast implant illness? Is it real? And if so, what does that look like?
I think after 6 years of just taking care of patients who've been affected by this, whether they're cancer patients or cosmetic patients, for me, I look at breast implant illness as a chronic inflammatory type condition. So if you just ask patients questions about the systems of the body, and you can start from head and go to toe, they'll have a complaint basically in every system of the body. And I feel like that's really confusing to a provider.
Yeah.
Because a provider, even a GP, will become a little bit confused about the number or the litany of things that patient who seems otherwise healthy is, unloading. And then the practitioner is like, whoa, this doesn't make sense. This doesn't line up. This doesn't I can't recognize the pattern of what's going on here, because when you're taught in school, you're taught to recognize patterns, and that's how you come up with a diagnosis, and that's how you then treat the patient. So I think that's the confusing part on the practitioner side. And then they'll say, all right, we're going to send you to the rheumatologist, or we're going to send you to the GI doctor, or we're going to send you to the ear, nose, and throat doctor, depending on the complaint,
right?
So that somebody who's more specialized can help, figure out what this is.
Yeah.
The problem is, ultimately, all those people, specialists, other providers that see the patients, don't come to a real conclusion about what is causing that, because chronic inflammation is not some, easily, diagnosable, easily treatable problem. You'll get people coming to me, who've seen multiple specialists who've been put on sometimes steroids, other immunosuppressant medications, but most often antidepressant, because they'll come to the conclusion that it's in your head, you're really anxious or depressed. And so I think, people ask me a lot, is there a test that I can do to show that this is the problem? And really, it's more of, the way I explain it is, everybody has a certain amount of genetic ability to detox.
Yep.
And over time, as you get exposed to more and more things, you surpass your ability. And then when that happens, you get in this bad cycle. And your immune system will say, for instance, you have an implant. It doesn't matter if it's a hip, knee, or breast implant. Your body doesn't like that that's in your body. Mm-hmm. So it sends out a signal to get it out of your body. That's your immune system. It's responding to it. And, between your ability to detox, hormonal imbalances, other nutritional problems, you get in this wicked cycle of what's become too much inflammation. Your body can no longer manage it. You put on weight, you get brain fog, you may get shortness of breath, palpitations. You definitely have a lot of gut problems, anxiety, depression, joint pain, muscle pain, skin rashes, neuropathic pain. I mean,
the symptoms. Yeah.
Basically, I've seen all those intractable UTIs, bacterial vaginosis, fertility issues. Whatever. If you can, come up with something, it's been said to me. So.
And it's really true even with what we've seen with patients, with working with so many patients. It depends on the person and the severity, like you said, like their bucket is just overfilled. So usually those patients who are coming to you that are like, I feel this is a big, big driver for me, right? Usually they have a lot of other things going on in the body. And then we have some other patients that are like, I don't feel like mine are impacting me yet, or I don't. So what do you say to people like that? Do you feel like everyone should get implants removed? Like, what are your opinions on that? And I know this is a loaded question, but we get that question a lot.
Yeah, sure. So, there's a genetic archetype that actually is very susceptible to this. So if you have a lot of toxic, or inability to manage toxins. So your vitamin D pathway, your methylation pathways, your antioxidant pathways, and really your glucuronidation pathway, those are the things that govern your detoxability. And so that everybody in the audience understands it. Once that's succeeded, then you get into this, problem of your body's just continuing to say, yeah, I'm inflamed, and it secretes these effector cells, and it stimulates you and stimulates you and stimulates you. So basically, in our patient population, it's usually 3 of 4 of those pathways are a problem. So you already show up with limited capacity. So working backwards, reverse engineering it, obviously when I went to school, we didn't have functional genomics. Right. The Genome Project was not complete because computing was not advanced enough to complete the Genome Project. And that's why there's movies like Decoding Annie Parker. I may have said it wrong. Annie Parker? I think that's the name of it. So she is the lady that they used to figure out the BRCA mutation, her family history. But it took so long because the computers were not advanced enough to actually figure it out. And that's really been, the limitation is the, like now we have AI. Okay. Yeah. Well, just go back to school. And if you knew genetics, the way I know genetics now about patients, it would really help you recognize patterns, because when people come in and start saying things, I start not thinking about what disease it is. I start thinking about what genetic problem they have.
Yeah.
And that's how I think about it. So it clicks a different way for me now. I've done over 3,000 consults for this, and I have genetic reports on several hundred patients and toxicity reports, and I've done over 1,500 explants. So like for me, it's a very quick, easy thing to recognize. And then, okay, this and this makes sense for you. If it's somebody who's asymptomatic, which is what you're asking about, and they come in, I don't say you have to do anything. Basically I get a bunch of people self-referring because they're either tired of having implants, leading a more holistic lifestyle, made a choice when they were younger that they wouldn't make now. So I'm not like, trying to, tell people one way or the other. I put implants in for 20 plus years for breast reconstruction, for cancer purposes. And I did a small amount of cosmetics, but my focus was oncology when I was, mostly doing that.
Are you still putting any implants in now?
No, I haven't for about 3 years.
Okay. So do you think, and listen, guys, we get it. Not everyone has the time, money, or the capability to commit to finding and working with a functional medicine doctor. And guess what? That's okay. You can improve your health and you can alleviate your symptoms in a different way, a much more convenient way. So head over to healthbabes.com/courses and check out our functional medicine at home programs. In those programs, you'll get everything you need to start thriving, feeling, and looking your best today. If you use the code HealthBabes50, you'll save $50 off the course. And this promotion is exclusively for our podcast peeps. I completely agree with the whole ability to detox and stuff. I mean, we see that a lot because we work with a lot of mast cell activation syndrome and stuff like that. And, most of our patients are terrible detoxers. I'm a terrible detoxer because of my genetics. So I completely get that. And so what do you think with autoimmune disease? Do you think that someone with autoimmune disease and maybe not a poor detox ability would maybe also be more likely to be someone to respond negatively to an implant?
Yeah, so I get asked that a lot. And so when I was doing breast cancer reconstruction, if someone had an autoimmune, pre-existing autoimmune condition, I wouldn't put an implant in them.
Yeah.
That was my preference because it's already the most difficult situation to put something in somebody. Doesn't matter if it's a hip, knee, or breast implant. So if there's lots of strikes against you to start with, obviously if you're going to lose your limb, then they're going to put a knee implant in or a hip implant in. There's alternative techniques if you're doing a breast reconstruction.
Okay. And so a lot of the testing, like the genetic testing, do you do a lot of that in practice for your patients too?
We try to get every single person to do it.
Love that.
Great. Yeah, that's so
great.
Good.
Yeah.
What about with the implants specifically? And I know anything foreign in your body can be an issue, but I've heard different things, that the implant collects a biofilm, and that can be a big problem for people, or that there's heavy metals associated with the implant or mold. Do you think it has to do with that or just more having a foreign object in general in there?
Well, I have an IRB to review my data set, and right now it's they're looking at 943 consecutive quantitative PCR tests of the scar capsule, which is the patient's scar capsule around the implant from my patients. And a simple audit shows that that's like 35% have a biofilm.
Wow.
Mm-hmm.
And so, there's three ways to get things at the time of surgery, as a, insertion problem, contamination by the staff, or later on in life as hematogenous. So you get something in your bloodstream, you get a virus, you get a bacterial infection, and that seeds an implant because the implant's foreign. So none of this is new. I mean, so people have had, mechanical heart valves and got endocarditis before, it's anything mechanical, anything foreign can get infected or have a biofilm. So, it doesn't matter if it's a hip, shoulder, knee, heart valve, dental implants, neural implants, I've taken care of everybody's problem from one time or another as a plastic surgeon because these things like, the neurosurgeon will call me like, oh, Rob, my patient's neural stimulator is about to be exposed. Can you see them?
Yeah.
And I'm like, they're like, yeah, I can read the serial number through it. That's a problem. So then you have to like take them to the operating room and you have to have strategies to help, salvage them, because that's something that helped their movement disorder if they had a tremor, or if it's a cardiac defibrillator, or, a knee implant or hip implant. I mean, these things happen to every single person who puts in implants. It's not unique to plastic surgery at all.
Right.
Yeah, that makes so much sense. Yeah.
Mm-hmm. And I'm sure you've seen amazing stories in practice, especially when you're working day in and day out with these people who are dealing with chronic illness. What are typically a lot of the things you see after the implants are removed? I know personally, I've known many people who've seen a lot of these symptoms and things improve. Can you share any stories or anything that comes to mind for you that would be impactful for listeners?
Yeah, I think everybody should understand that the implant is just one driver of inflammation because it's foreign. We do food sensitivity testing and stool testing, toxicity testing with urine for heavy metals, mycotoxins, phthalates, organophosphates, MBPs, BPAs, because there are all sorts of other things that affect you environmentally. And if you don't understand that, then you may explant and not necessarily do better.
Right.
So a more well-rounded approach, understanding functional genomics and then the aforementioned testing plus hormones are a big problem. And I would say for the audience, what you should understand is the number of people that come to me with a hormonal imbalance is plus 90%.
Yeah. That makes sense.
The thyroid goes off for all sorts of reasons. It's seemingly the most sensitive hormone we have, basically, especially for women. So with or without implants, people have, developed Hashimoto's and all these things. The next is the sex hormones get incredibly erratic based on their genetics. So if you can be estrogen dominant, you can be co-dominant, or you can be androgen dominant. Mm-hmm. What I see a lot of patients have they're already estrogen dominant. So they already have real problems with their periods. They may have PCOS, endometriosis, but they're estrogen dominant. And then when they get a fight or flight type situation going, more cortisol, it just makes that worse.
Right.
And testosterone really helps buffer that out. And as a standard male needs, say, 1,200 milligrams of testosterone, a woman would need 1/12 of that, like 100. But when we look at their sex hormone levels, they're typically high estrogen and very suppressed testosterone. And so there's no buffer then. So then all the effects of cortisol and estrogen are actually worse because they're not being buffered out at all by testosterone. So for many of our patients, we try to get obviously their gut working better and get their hormones balanced first holistically with supplementation. We have our own package for lowering inflammation and supporting hormonal health. But if it's really bad around the time of surgery, I do just our own hormone replacement with a pellet.
Wow. We see a lot of the time people will get, they'll explant and then they'll say, I'm not better. And we're like, well, we have to work on your detox pathways. We have to work on your gut. We have to work on all the other issues. Just like you said, it's usually just a piece of the puzzle. And that you see how disappointed people get, on the Facebook group or whatever, because they're reading other people's stories and they're expecting to explant and their whole world's going to change because that is the report of some people. But we really try to explain to people, it's a whole process. Just like you said, it's really not just explant. You have to work on all these other things that were causing the inflammation in the first place too, because there's usually a lot going on. So I love that you do that approach because so many people don't tell them about everything else that they need to support as well. And then people will get disappointed with their results if all they're doing is explanting with no other support.
Well, what a lot of folks do now is not everybody can come to Austin and have surgery with me.
Right.
But our surgical recovery program is ran remote. So anybody can leverage our program. So that in itself is a big advantage. So if someone can't travel, it doesn't work logistically, then they still can benefit from the program. The program set up to run really for both the breast implant illness population and the surgical population at large.
That's great.
Yeah.
So can you dive in? I know you have a certain program. What's the name of it again?
HARP.
Yeah.
Holistic Accelerated Recovery Program. And I had really great mentors who taught me, and they were very strict when we were in surgical training. They would not allow you to use specialists to take care of your patient. You had to know and take care of everything about the patient. So it didn't matter what it was. You were running that for the patient. It was their nutrition or their medications for their heart, or it didn't matter. So that was not ever a big stretch for me to do, nutritional support counseling or understanding different medications if somebody was on something. The things that are a little bit different, obviously, are supplementation or use of nutraceuticals. My interest in genomics has been around since I was in college, so I've always been interested in genomics. So we've just, through company relationships, got better and better genetic testing over time. And now many of the companies that only took care of either celebrities or professional franchises, sports franchises, or C-suite executives are now public facing, and you can utilize them and their information. So the crux of the program lies on genetics. Like, you can't pick your parents. It is what it is. You got these genes, and then whatever the environment gives you is the other, we don't know type question that I have to answer most of the time. If you live in California, Florida, anywhere on the coast, I think you have mold. So you got to prove that.
I'm in Florida. Yeah. It's bad. It's bad here. That's actually when I explanted, is when I was living in mold. And I thought, this has to be my implants. There's nothing else wrong with me. And I can smell mold from a mile away. I could not smell the mold. I was literally, it was under my bed in the ground, and it was killing me. I mean, I felt terrible. And then I explanted thinking, okay, this is going to be the thing. And a week later found that there was mold.
Well, that's part of it, right? So people ask me, like, why do I do all this? And your explanation is why. And you'll have instances where people go, I used to refer people out because I have a really good relationship with functional medicine providers in Austin. But when COVID happened, you couldn't really send anybody anywhere. We just brought it all in-house. And the testing I was very familiar with, the genetic testing, which was the kind of game changer, became more advanced year over year over year. And now, just knowing as much as we know about personal genetics of our clients, we back it up with, the testing for toxicity. And most people don't understand, like, all the different things they're getting exposed to. It's not really talked about enough, So the air you breathe, the water you drink, the food you eat, those things are all difference makers. And I have people have tons of problems in their GI tract, and it's not hard once you understand how bad the food is. But the mold is that is a big wild card, and I just listen to people. So people with mold have brain fog, a lot of neural inflammation, light and sound sensitivity, anxiety, fatigue. So it all kind of falls into the same symptom pattern. But if you don't look for it, you'll miss 100% of the things you never look for. So we check them all the time. So
you got to look at the whole body and their environment, genetics, everything matters,
So when it comes to fat transfer, like you mentioned earlier, is there any danger, in your opinion? First of all, let me ask you, this is a two-part question. One is, when someone is explanting and they're going to do fat transfer, do they explant at one surgery, wait, and do fat transfer, or do you do that at once?
So I won't do a fat transfer at the same time without knowing their toxicity testing and being able to have them in some sort of phase 1 detox, because invariably the people who need it the most have the most toxicity, if you just want to think of it that way. So you have to look at them and get them on a program to lower their inflammation and address whether it's mold or heavy metals or phthalates or glyphosates or BPAs, whatever. You have to help them preemptively, because you're before I would do them and I would get very good retention results, but the further you go along and the sicker the patients, the more chronic inflammation there is. Fat transfers work because stem cell activation works and hormonal influence works, and moving fat from one place to another works. It's been around for 100 years. It's nothing new.
Yeah.
The thing with the explant, population is you don't know in each given instance how much toxicity there is in that given individual. And I always tell my clients, and I had somebody here yesterday just for a fat transfer. And I said, all things being equal, if I can make you more like your 30-year-old self, this works every single time without question.
Mm-hmm.
So, consider like a buttocks fat transfer. It's been, 20 years ago in South America, it became very popular. And now 10 years ago in our country, it became very popular. And it's still to this day is very popular. Much bigger space to put fat in. You can put it in above the muscle, but much broader area to put fat in. Works. But why does it work so well? A lot of younger patients normally.
Yeah.
So if you're following, I'm just trying to take you back to get your hormones more like when you were a 30-year-old, and get your diet correct, cut out gluten and dairy and a bunch of processed anything and sugar and things, just try to get these things in line and make sure your gut's functioning and you don't have a lot of toxicity. And then of course it should work, and it will work.
Do you think there's a danger with putting fat into the breast tissue, like an increase in cancer risk?
Fat doesn't go in the breast tissue. So it
or
goes
like
beneath the skin,
right
above the breast. And no, so breast cancer is an epithelial cancer. So fat is mesenchymal. So it's not going to give you a breast cancer. It can't.
Okay.
Wow.
We've been told that. That's why I asked. And
so
the
only
really
breast
understand.
cancer that's mesenchymal is called a phylloides tumor. It's very rare. So I had to present this information years ago at a meeting because there was between like 2000 and we'll say 5 to, we'll say 15 probably. There was a lot more, discussion about, is this safe to do and will it cause a problem? And there'll always be people who, I'm pretty conservative, but I'm not worried about it in terms of this. The tissue of origin is different for breast cancers versus fat.
That makes sense.
And I used to, so for the audience, I used to do fat transfers on breast cancer patients all the time.
Wow.
And it didn't increase the incidence of breast cancer.
That's so great. Such good, because you can be left deformed. I mean, when I got my implants out, I was really upset because it wasn't cute.
And that's why I do a lot of simultaneous transfers. And we know that. And, just the other day I was doing a consult and somebody asked me if they were going to be, it was a spouse asking me, I'm worried about my wife being unhappy with the aesthetic result. And I'm like, well, okay, if you take something away volumetrically, nobody's going to be happy. So that's just a foregone conclusion. So the point is, if someone has tissue, can I reshape it? And that will give them, a better position of the nipple and a better shape.
Yeah.
And then invariably the cleavage area and the upper portion are what are hollowed out. And that's what, from your view, you're looking at all the time and you're looking in the mirror. And so that's where a fat transfer can help. It's not the same as an implant, because an implant pushes tissue out because it's rigid. Fat layers over the breast that exists, and that allows you to have more volume. So it's a more natural, holistic, way to do a rejuvenation or reconstruction, depending on, what you're doing. But the appearance change is not going to be as dramatic. And I use it as a way to bridge that gap between someone experiencing, a difficult outcome right away, versus, waiting and doing it staged. I've done several hundred that way. I mean, it really depends on the patient and how sick they are to begin with. If it's a super sick person, then I just tell them, okay, program and toxicity testing and supplementation and explant get done. And then you wait 6, 9, 12 months, get yourself, back online with our detox practitioner, and we'll get it taken care of. And many times you can do small fat transfers under local in the office, and that's enough. Or if someone needs multiple areas done to get enough fat, then that's something we do under general in the operating room.
Okay. This may be a silly question just because I'm a little naive to this, but when you're doing fat transfer for the breast, where do you take the fat from typically? Like, where is there better areas than others? Like, are there people that are just not good candidates for that?
Yeah, I mean, usually, so it's a two-parter, right? So the most common areas are the inner outer thighs, the waist, and the abdomen. It's the same thing we would do for a buttock transfer. The thing is, you got implants typically for a reason. You're a lower BMI patient, you didn't have a lot of breast tissue, and that gave you volume. So typically the people who have the most trouble are the lower BMI patients, and how much can I, safely take for them? And for the listeners, there are very safe ways to do this in thinner, petite, more athletic, low BMI patients that does not give rippling or contours or abnormalities or dimples. So it's a specific way to do it. The areas stay the same. Now, I will say the caveat is if someone's had kids, you have to be more conservative on their abdomen, and then I add skin tightening because that's been stretched out typically from a pregnancy, and you don't want to make that problem worse. So I have something called the smart tummy tuck, but nonetheless, we have a lot of skin tightening technology, which is bipolar radio frequency technology to help tighten it. I do it at the same time. And, I don't ever want to, take fat out and then whether it's 2 years, 5 years, 10 years down the road, somebody's coming back, hey, this doesn't look right. You want to try to tighten that skin to help them.
Yeah, because it can look weird if you don't.
Looking for more freebies and resources, head over to healthbabes.com to get your free liver support guide. We all know and are learning that supporting your liver is so important for so many things when it comes to health. It's a master regulator, metabolizer, detoxifier. Supporting the body's natural detox pathways is important for overall health and well-being. And that's one thing that me and Beck have found out working with so many patients throughout the years. Once you really start working on your detox pathways, you start to see a lot of things unfold and other things start to get better, right? And so over at healthbabes.com, you can also find a full list of our favorite trusted food, beauty, and health products. Use HealthBabes50 code at checkout for any of our popular at-home health courses. Again, you can find our free liver guide and health courses at healthbabes.com.
Right.
Mm-hmm. So when you said Zoom call, it kind of triggered something. So have you noticed a big uptick in cosmetic surgery since, COVID, and then everyone was doing things on Zoom? I've heard that the amount of cosmetic surgery has, I don't know the number, tripled or whatever since people were seeing themselves on Zoom calls all the time. So, and I know you're not just cosmetic surgery like that, but have you seen a lot of people much more concerned with their appearance and coming in for more things like the skin tightening? And I want to talk about your no-cut facelift, but things like that, have you seen a big increase in that?
Yeah, during COVID, we had everybody still had the interest, and then it was limited by what we were, able to do. And we had some non-invasive technology that we added called Evoke, and that would help contour the jawline and the chin area. Totally non-invasive, like wearing a pair of headphones on the area. Mm-hmm. And then we have the minimally invasive things like Face Tight, AccuTight, Body Tight. Those can be done all over the body to tighten areas of skin relative to, how big of an area and where. And then I have some proprietary cellulite treatments. And as you mentioned, the facelift treatment that doesn't utilize a knife called the no-cut facelift. And then we have stem cell therapy in our office. So the appetite for, aesthetic improvement has increased for sure. And then during the lockdown and shortly after, I had a lot of people requesting things for their neck. and the
Yeah.
face.
That's what I heard.
So,
Yeah.
we do something called the Zoom lift, which is just
Yeah.
a neck lift that is done through little openings about 1.5 to 2 millimeters. So you can't see the opening once it heals. And so I think the goal really for, both your and my generation, and for that matter, the generation above and below, is facelift scarring, neck lift scarring is very stigmatizing. You can see the scar forever, much like a hairline scar for a brow lift or any of those things. So having done all those in my career, I've always searched for ways to avoid visible scarring. Mm-hmm. So with the no-cut facelift, it's basically we do deep skin tightening with Face Tight. And then we do basically the neck lift as needed. So the bands of our neck are what make our necks look bad. Mm-hmm. And that's the platysmal bands. They hang down as we get older. When we're younger, they're just tight up against our neck. And we can do that through those 2 millimeter openings. So you can do deep facial tightening with Face Tight. You can do a Zoom lift or a neck lift through small openings. And then the final thing is, and probably everybody who's listening, is sort of microneedling. So microneedling is not new. You can do microneedling, as a standalone. You can add energy to it. It can be what's called monopolar, so the energy comes out the tip, or it can be bipolar, where it comes out of a tip, hits a faceplate, and all the actions between those two. So we use bipolar just because of energy efficiency, and it to me is the most safe and reproducible manner. So I did that for a long time and got really nice results. But microneedling is a great collagen builder, not a great visual changer. So people who come in want visible change and or to feel tighter. So if you don't get any of those things accomplished for the client, they feel like, is this really worth doing this?
Right.
So now, basically in the no cut, instead of microneedling, we do microcoring. So we actually take out small 0.5 millimeter slivers of tissue. And the device we use is called Ellacor. And if you just take from neck, like collarbone, up to my forehead, the settings we use allow us to take 26,000 microcores out. That's almost 2 square inches of skin.
Wow.
And there's no scarring because it's so small. So
Dr. Rob, you're about to get busy.
Right. I have a lot of media folks come for that from all over the country. And then the thing that we like to do, and so as everything, like I enjoy knowing someone's genetics, but now we have stem cell capability in my office. So we can take your fat from your waist area, if that's the most easy location, typically is. And in the time it takes me to do the facial treatment, we can then end it by adding your stem cells back, IV or through topical application on the face.
Wow. That's so cool. So for people who don't know, like what exactly would be the benefit of doing that?
So your own stem cells are naturally, they're going to home to where the injury is. Mm-hmm. So I just did the treatment on your face, and everybody wants me to, do everything I can to get them healed up more rapidly, make them more beautiful, and do it for free with no scarring. So all things being equal, that will get you the most rapid wound healing, your own stem cells.
Wow.
So cool.
And what's like the healing time, the turnaround time? Could just kind of walk us through that.
On what? The no cut facelift, Crystal?
Yeah.
So anybody who's had a no cut, if you've ever had microneedling, you get like red, and that may stay for a couple of days, and then you'll have a little textural change.
Okay.
This is different. So this is hollow. So you're actually taking a piece of skin out. So for the protocol in my office is you come in or you fly in. If you're doing stem cells, we start by harvesting the fat. Then we do the no cut procedure. And then at the end, we add your stem cells back to the area we treated. Then we cover that with a couple other topicals. And then I have a hyperbaric chamber in my office. You go in the hyperbaric chamber. And then typically everybody's in town 3 to 5 days, depending on their turnaround. Okay. So I try to do as many treatments for them with hyperbaric and or lymphatic treatments before they leave. And then so that for folks who have to turn their cameras back on and do media, it's about 5 days before they can get cover up on and everything. And it really depends on your skin type, how much brightness you may have. It varies. People who are a little bit more olive will be a little bit darker. And then somebody who's like super, super pale will be brighter as well. But on average, everybody gets their pigment down relatively quickly so that next week they can be doing things. And that's not too different from, if I did a facelift in general.
Mm-hmm.
Have you ventured into the awake surgeries or the at least twilight versus general options?
So all my facial stuff is awake.
Mm-hmm. Wow. Okay.
Yeah. Even when I did traditional facelifts, I did them awake.
Wow. And what about like if you did a breast, like a explant, is there an option to do that without general?
So the explants where the patient's implant is behind the muscle, it requires general. Mm-hmm. And then above the muscle, it's just patient preference normally. But if you're doing a fat transfer and other things, it becomes more the purview of general, just for comfort for the patient.
Yeah. I was just wondering because of the people who already have an issue with detox, having the anesthesia.
Oh, so I'll mention, so I'm glad you mentioned that. So basically I've done about 900 cases with the same group of anesthesia providers. And so it's very simple for me. I run what's called an ERAS. And basically you take a series of medications starting the night before surgery, and they're meant to calm down the nervous system, reduce inflammation, and decrease your propensity to have nausea and vomiting. And so when you come in the next day, you're calm, instead of being ramped up and anxious. Mm-hmm. And then it makes it easier for anesthesia in general. If you're calmer, then they're not apt to give you as many things to calm you down. Or when I start the case, we have things we do with local anesthesia. And then as soon as I get one side of the explant done, I use a long-acting local anesthetic called Exparel to numb the rib surfaces and the tissues where I was operating. So then you see everybody's heart rate calms down. And so each time I get done with the side, I do that. And then we don't use drains in my practice. I wrap everybody up and use ice right away. So my patients typically will come out with a lower pain score. It will take very little to get them comfortable, especially just a straight explant. When you're doing fat transfers, you have sites of fat removal and or liposuction areas that will be different, and you can't control them with the same pain medicine I'm describing. But that being said, everybody's got already on board medication, and then they're given either in the operating room or in recovery room, just short acting as they need it. So they're not really groggy. They don't stay there very long. Most of my patients are only in recovery 30 to 40 minutes before they leave.
Okay. Wow. That's cool.
That's great.
Yeah. It sounds more like Twilight, or the way Twilight would be described sounds more like what you're describing. Cause when I've had general anesthesia, cause I'm such a poor detoxer, I cannot recover. It will take me weeks to feel halfway normal again. So that's,
yeah, the day after surgery. So yesterday I operated. So the patients from yesterday will come in today and get hyperbaric done. So that also helps clear and make them feel better sooner. I don't want to say it clears every aspect of general, but it does help you feel better more quickly.
That's great. Well, we love what you're doing. This is so great because, everyone, not everyone, but a lot of people are interested in looking better and feeling the way, or looking the way they feel maybe, or, whatever, however you want to word it. But there's some fear, as far as, what are the scars going to be like? Am I going to be judged because everyone knows I had a facelift, or whatever the concern is? And I think even with explanting, what am I going to look like? What, and how is that going to affect me? So I think it's just so cool that you are just looking at all these different things and trying to help people be able to do these things without feeling so different from where they originated, as far as what they look like and how their healing time. And then with the explanting, it's just so great that you're looking into all the other things that are causing that. inflammatory cycle, because I don't think anyone else is. There really aren't. They will have to go to someone who's going to help them with the Explant, and then someone like us, functional medicine practitioner for all the other stuff, and that can be hard. So,
we do have a practitioner training program now.
Awesome.
So we have a series of modules set up for that, and then we have a surgeon training program. Wow. So the things that are complicated in terms of, I don't know what to expect if we do this. Like that's been worked out in our practice. So we have that for the practices who are interested in our practitioner training program. And then for me, if a surgeon wants to learn how I do this, they can come to Austin and we'll take them through the process. And it doesn't take surgeons, I would not say it will take them very long to understand, the
process and
nuances of it. We feel like, if you think of chronic inflammation as a promoter of aging, which that's what I consider it. This is both from a breast perspective way to decrease your speed of aging. So if I do an explant and a holistic transformation with fat, I've helped you in terms of aging. If we do a no-cut facelift, I can change how your face ages forever. And then we use your own stem cells to help you. And you can bank your stem cells and use them later. So there's lots of more precise, individualized ways to practice.
Yeah. Well, we hope everyone takes your courses, because people need to know this stuff, and people need to go to someone who is doing it the way that you're doing it. So thanks for, just learning and sharing and everything that you do. It's just so great. So we're so happy that you came on. You gave us so much great information, and we thank everyone for listening.
Thanks for having me.
We hope you guys enjoyed this episode. If you did, if you can pop over and leave a review, that would be awesome. You can also find us over at healthbabes.com, where you can find our courses, our latest book. We also are on Instagram at The Health Babes, at Dr. Becky Campbell, or at Dr. Crystal Hohn. I hope you guys have a great rest of your day.